Okay, welcome this afternoon, everyone. Thank you for coming to our virtual event for the month of September. One of the cancers we would like to recognize is ovarian cancer. And so today we have several speakers that's lined up that's going to provide some great information. And so we look forward to you all joining us. And throughout the presentation, please have your questions, put them in the chat. We would try to answer them the best we can. If we're not able to get to your questions, we would try to get those questions, those answers to your questions after the event. So today's title is Ovarian Cancer, Signs, Symptoms, Early Detection and Treatment Overview. So this is the agenda we're going to follow today. Just do a welcome and an introduction. The first presentation is going to be on ovarian cancer. The second presentation is going to be by a genetic counselor. And the third presentation is going to be by ovarian cancer survivor. And she's going to talk about her journey. So I'm really excited to hear her story. And I want to thank her in advance for being transparent and sharing her story with us. We will have a short question and answer period, about 10 minutes after all the presentations, and then we'll give you some information on some upcoming events. Just so you'll know, the Office of Health Equity, we are trying to be the leader in reducing cancer disparities. And we do that in multiple ways, but one of the main things that we do is outreach through the community, do events with the community. In this particular venue, because of COVID-19, we cannot actually be out in the community. We are doing things virtually. So this is our way of getting information to you, and you have the opportunity to speak to some of our specialists and care providers that are actually providing the care. We also have patient navigation. So anybody that attends this meeting, if you know someone that are in need of services, need cancer screening, please give them our contact information, send us an email or call us, and we'll try to help them no matter where they're at in the state of North Carolina. We also do educational health disparities, which is part of what we're doing today. And we also teach individuals about clinical trials and how important it is to be involved in clinical trials. And we want you to know about clinical trials before you actually need them. So the first speaker we're going to have today is Dr. Secord. She's the Associate Director for Clinical Research in Gynecology Oncology at Duke Cancer Institute. She received her medical degree from the University of Washington School of Medicine. She completed her residency in OB and a fellowship in gynecologic oncology at Duke University Medical Center. She is an expert when it comes to ovarian cancer. She's on the National Cancer Institute Ovarian Cancer Task Force. She has chaired or co-chaired multiple national committees. She has over 180 peer-reviewed articles. She conducts a lot of research, and she's really interested in gynecologic cancer, novel clinical trial designs, as well as the role of obesity in gynecologic malignancies, as well as developing patient-centric composite clinical endpoints. Now, her colleague, Dr. Rafael Gonzalez, is in the operating room right now, taking care of patients, and we know that patients have priority in everything that we do. But I will introduce him. Dr. Gonzalez, he completed his undergraduate degree in medical school at Brown University in Rhode Island. He completed his residency in OB at Brigham and Women's Hospital in Massachusetts General Hospital in Boston. And he spent the first year of his fellowship working in health services research, aiming to improve healthcare delivery for women in gynecologic malignancies. So now I introduce you, Dr. Secord.
Oh, thank you so much, Dr. Morris. Such a kind introduction. And I'm so sorry Dr. Gonzalez won't be here with us today. I know he is as well. But as Dr. Morris stated, patient care comes first. So it's our pleasure to present this information regarding ovarian cancer signs, symptoms, early detection, and treatment overview. And my hope is by sharing this information with you tonight, that you will be able to identify these symptoms if you should have them, or help your friends and potentially identify a case of ovarian cancer early rather than later. Next slide, please. So this is my verbal disclosure. I do a lot of clinical trials, and so Duke gets a lot of funding for clinical trials, and part of my salary comes from those grants to Duke. I also have participated on advisory boards, and I serve on several steering committees for clinical trials. Next slide, please. Today, what we'd like to do is review the incidence and risk factors for ovarian cancer, discuss signs and symptoms, which is incredibly important for early detection, review treatment options, and review preventive measures for ovarian cancer. Next slide. I could talk for a whole day about ovarian cancer, so boiling this down to 15 minutes was very hard for me. But what I like to do is just talk about ovarian cancer in general. So collectively, ovarian cancer refers to not just ovarian cancers, but cancers of the fallopian tube and peritoneal cancers. And if you look at this little figure up here, you see these tiny white things, which are your ovaries. The structure that's overlying that, like a cap, and then going to the uterus, are your fallopian tubes. And we think that now most of these cancers are actually coming from the fallopian tubes, and the ovary just gets blamed for everything. But the other type of cancer that falls in line with these two cancers are peritoneal cancers. In the United States, there's approximately 21,000 ovarian cancers each year, and there's about 14,000 deaths. And those numbers have considered to go down, which is great news, but it is the highest mortality risk for all the gynecologic cancers, and it's the 5th most common cause of cancer death in the United States. Well, what does that mean for North Carolina? There's about 680 new cases each year, and 410 women die from this disease in our state. Overall, not just for women in North Carolina, but for all women, there's a 1.2% risk of developing ovarian cancer. And the prevalence in 2018 was actually over 200,000 women had ovarian cancer. So it no longer was a rare disease. And what this actually means is good news. It means women are living longer with this type of cancer. Next slide, please. I just want to show this table for you. If you look down at the bottom, that shows the mortality figures. And you can see that while ovarian cancer is just not as frequent at all, it doesn't even make that top list there in the table in terms of the incidence. It accounts for a significant number of women who die from cancer each year. In fact, it's about 5% of the deaths for a very rare cancer. And that's because most of the time it's diagnosed at advanced stages. Next slide, please. But the good news is what we've seen over the past few decades is this continued decrease in the incidence and mortality rate. So incidence here is shown in that light green curve, and death rate is shown in that darker green triangles. And what I'm pointing out here is that in 2013 and 2015, Angelina Jolie made big announcements. She had op-eds in the New York and the Times, I believe, and she stated that she had a BRCA mutation and she was actually a carrier, and that her mom had also been a carrier. Her mother, you may know, died of ovarian cancer. And in 2013, Angelina Jolie had a mastectomy to prevent breast cancer. And that was followed by removal of her gynecologic organs to prevent ovarian and tubal cancers in 2015. And what you do see with this curve is that there's a pretty stark decline in the incidence of this disease. And what I'm wondering if that spurred women to get tested, get genetic testing. And if you have this mutation abnormality, you can do things to prevent these types of cancers. And we're going to talk about that a little bit later, but the specific procedure is called a risk-reducing salpingo-oophorectomy, which is very fancy words that mean remove your ovaries and tubes. Next slide, please. Let's talk a little bit about what types of these cancers are. Most of the ovarian cancers that we think of actually come from the surface of epithelium of either the ovary or, as I mentioned, the fallopian tube is the #1 player here. And the most common histology is serous, and that just refers to how it looks under the microscope at 75%. There's a whole bunch of other types of ovarian cancers, and I listed some of them here, like low-grade serous, endometrioid, clear cell, mucinous. There's also cancers that come from other parts of the ovary. So instead of that outer surface of the ovary or the lining surface of the tubes, these cancers come from these cells within the ovaries, like sex cord stromal tumors or germ cell tumors. Next slide, please. So we're going to focus our conversation really on epithelial ovarian cancers. Those are the most common types of cancers we talked about. So the average age of onset for ovarian cancer is 63 years old. So older age is a risk factor. And another big risk factor is a family history of ovarian, breast, or colorectal cancer. So there's a syndrome called hereditary breast ovarian cancer syndrome. And then for colorectal cancer, you may have heard of something called Lynch syndrome, which is characterized by not just colorectal cancers, but other types of cancers such as ovarian and endometrial cancers, as well as several others. Up to 25% of ovarian cancers result from an inherited gene mutation. So it's really important for us to screen patients, get genetic testing, and try to identify if they have this gene mutation. And there's a lot of reasons it's important, and I'm going to talk about that a little bit later too. So identifying if you have a personal history of breast cancer, something called endometriosis. Endometriosis increases the risk of ovarian cancer by about 2 to 3-fold, which sounds really huge, but you have to remember this disease is very rare. And so even if you're increasing it by that amount, really that translates to about a risk of 3 to 4%, which is very small. If somebody hasn't had any children, that's called nulliparity, or their first full-term pregnancy was after the age 35, that may put them at increased risk. Estrogen replacement therapy or hormone replacement therapy, obesity, fertility treatments. Now that's an area of controversy. Part of that may be that people who are less likely to have children or are nulliparous are more likely to have fertility treatments. Smoking, interestingly, is linked to an increased risk of mucinous ovarian cancers. Next slide, please. Let's talk a little bit more about BRCA1 and 2 genes. I'm not going to spend a lot of time on this because Maggie Powell is going to give an excellent talk on this as well. But the cancers associated here are breast, ovarian, tubal, primary peritoneal cancers, and also pancreatic and prostate cancers. If you have a BRCA mutation, your lifetime ovarian cancer risk is 35 to 70%. And if it's a BRCA2, it's much less, 10 to 30%. Next slide, please. Now, this other type of syndrome we talked about was Lynch syndrome. Lynch syndrome is comprised of actually a collection of different genes here. There's 5 different genes, and there's probably over 40 gene mutations that are pathogenic. That means bad ones. And not only is it associated with ovarian cancers, but it's also associated with the colorectal cancers, as we've mentioned, as well as gastric, small bowel, pancreas, prostate, brain, skin. The lifetime risk of ovarian cancer, if you have this mutation, really depends on the type of mutation you have, anywhere from 1 to 38%. So the highest we see are in patients who have MSH2 or EpCAM mutations. But if you have a PMS2 mutation, that risk is actually pretty low. And I demonstrate that here on this table. And the average age of presentation ranges anywhere from 43 to 59, depending on the type of mutation. Next slide, please. There's other types of hereditary cancer syndromes as well, but these are very rare. There's one called Peutz-Jeghers syndrome, which is associated with sex chromosomal tumors. And another one, and the other ones I listed here are a variety of different genes shown. One notable one is SMARCA4, which is associated with ovarian cancer called small hypercalcemic cell type. And then there's TP53 mutations that are associated with Lee-Fermuni syndrome. But having said that, a lot of ovarian cancers have this type of mutation, and it's just something that happens spontaneously. It's not because you inherit it from your mom and dad. Next slide, please. Well, what can we do to lower risk? So pregnancy and breastfeeding can lower your risk, especially if you had a term pregnancy before the age of 26. Birth control pills can lower risk, as well as just doing a tubal ligation. And that tubal ligation could be just clamping across the tube or burning across the tube. What we like to do now, though, is something called a salpingectomy. And that's a little bit lower down on this slide here. But what salpingectomy means is that you completely remove the tube. And so if women are desiring to have a tubal ligation now after they've had their children, or they're having surgery for another indication with their female organs, if they're done having children, we will remove their fallopian tubes after a thorough discussion of the benefits and risks. Hysterectomy, even if you leave the ovaries or tubes, is thought to be protective. And we talked a little bit about if you have one of those mutations, like a BRCA1 or 2 mutation, or the other mutations I mentioned, you can undergo a procedure called risk-reducing salpingo-oophorectomy, where we remove the tubes and ovaries. And sometimes some of those patients, we also talk about removing their uterus as well. So that would be a risk-reducing hysterectomy. Next slide, please. The most important part of my talk today is really the signs and symptoms. There's no great screening test, I should say, for ovarian cancer. And so what we found is that even though these symptoms are nonspecific, if women have them daily for 2 to 3 weeks, it could portend that they have this type of cancer. So the symptoms are bloating, pelvic and or abdominal pain, abdominal distension or swelling, shortness of breath, difficulty eating or feeling full quickly, urinary urgency or frequency, or if there's a change in their bladder or bowel habits. Often women experience these symptoms every once in a while. They may come and go, especially associated with their menstrual cycle, but it's not uncommon to have some of these symptoms. The key here is that if you have these types of symptoms, and you don't have to have all of them together, it could just be the abdominal distension and swelling. If you have that every day for 2 to 3 weeks, you should go seek medical attention. And you might need to bring up to your doctor, could this be ovarian cancer? Could this be tubal cancer? Because it may not be on the radar for all doctors. Next slide, please. Well, we already talked about there's no great screening test for ovarian cancer, but women who are at high risk, they have one of these BRCA1 or 2 mutations, or they have Lynch syndrome, we do talk to them about doing a pelvic exam. You can also add transvaginal ultrasound or CA125, and I often will offer that to my patients every 6 months. But the most important thing is really talking to them about the symptoms to watch for and signs to monitor and to seek prompt medical attention if they have them. We are continually searching for an ideal screening test. Next slide, please. Well, what about treatment? So the treatment options, really the cornerstone of treatment is surgery and chemotherapy. And traditionally we used to do surgery first, followed by chemotherapy. But now in some patients, we're doing chemotherapy first, which is called neoadjuvant chemotherapy, followed by surgery and then more chemotherapy. The goal of surgery, we remove all the female organs, the uterus, cervix, tubes and ovaries, the omentum. And if they have advanced disease, we do a procedure called debulking. That just means remove all the tumor that we can see. If they don't have advanced disease and they have early disease, we'll do something called staging. We'll remove the lymph nodes and do a whole bunch of biopsies to make sure the cancer hasn't spread any further. And then the chemotherapy, really the cornerstone of chemotherapy are 2 drugs called paclitaxel and carboplatin. There's other drugs that we can add. One is called bevacizumab, but it does increase risk of side effects. It does improve disease control, but it doesn't necessarily help people live longer. There's other drugs that we deliver directly into the abdominal cavity. Sometimes it's called belly wash. And this is one of the options here is HIPEC or hyperthermia intraperitoneal chemotherapy that we give at the time of surgery. And then another one is intraperitoneal therapy where we put a little tube into the belly and deliver therapy inside the belly every 3 weeks. We've really moved away from this last one. But there's a lot of interest in the heated belly wash therapy that you do one time at the time of surgery, but further research is needed to make sure that this really works. In terms of maintenance treatments, those are treatments that you continue after chemotherapy. You can continue bevacizumab if it would have been started already with the chemotherapy, or the drug that we're really using a lot of right now are PARP inhibitors. And we're really excited about this drug, especially in women who have BRCA1 or 2 mutations, or in women whose tumors have this mutation, or they have something called homologous recombination deficiency or genomic instability. You can also offer PARP inhibitors to patients even if they don't have these biomarkers, but it doesn't quite work as well. So following surgery and chemotherapy, about 80% of patients, even these are patients with advanced disease, will enter a complete remission, which is really exciting. Next slide, please. So genetic testing, I'm going to leave this more to Maggie Powell, who will talk about this, but we strongly recommend that all of our patients get testing. There's a lot of benefits in terms of understanding prognosis and actually determining if you're a candidate for PARP inhibitors. As I mentioned, everyone may be a candidate, but by doing this testing, we'll be able to determine how much you'll really benefit. The prevention of other types of cancers, if you have one of these genetic mutations, like prevention of breast cancer. And then really importantly, knowing this information so you can tell your parents or your siblings and your children to go get tested, because that will identify if they have these genes and we can talk to them about preventive strategies for cancers. Next slide, please. One thing I do want to raise is the disparity issue. We know that there's differences in health care disparities for women of different racial and ethnic groups. We don't quite understand what is leading to these disparities. Some of it could be access to care. Obviously, it could also be due to the molecular biology, like what is making up these cancers. But what we do know is that we need to make improvements here. And I've just circled the data for ovarian cancer that shows that Black women don't have as long as a 5-year survival compared to white women, which are shown in red. So we need to try to make sure we have health equity for all of our patients. Next slide, please. And prevention, talk to your doctor about your personal and family history. Then genetic counseling and testing can be done if indicated. If you have a hereditary cancer syndrome, talk to them about screening options. I've mentioned the pelvic exam, CA-125, and ultrasound, but the most important is really an exam, including the pelvic exam and understanding those symptoms and side effects. If you do have a hereditary cancer syndrome, they can talk to you about risk-reducing surgery, but they can also talk to you about other options like oral contraceptive pills that can reduce the risk of these cancers. And just as I mentioned before, really be aware of those signs and symptoms. Next slide, please. We've had a great month so far. We had our Gail Parkins Memorial Ovarian Cancer Walk and 5K run last week here at Duke. I urge you just type this into your internet and see some of the pictures from the event and how much money we were able to raise. All the funds go to Duke. There's other great resources out there too, the Foundation for Women's Cancer, and then the National Ovarian Cancer Coalition. Thanks, Dr. Moore, for giving me this time. It was a pleasure to be here with you all this evening.
You are welcome, and thank you very much for that excellent presentation. And she will be around at the end so we can have some questions. I learned a lot. I don't know about you. And so our next presenter is Maggie Powell. Maggie is a certified genetic counselor at the Duke Clinical Cancer Genetics. And she received her master's degree from the University of North Carolina at Greensboro. Like I said, as a certified genetic counselor, she helps patients better understand their risk for developing cancer and provides guidance on how to turn this information into action in order to reduce cancer occurrence or increase early detection in patients and their family members. So I introduce you, Maggie Powell.
Thank you for that introduction. I'm excited for this opportunity to talk a little bit more about genetic testing and genetic counseling. I'll be giving you all a version of a mini genetic counseling session today. So we can go on to the next slide. And you can go ahead and click through to the end of the slide. I'm used to using lots of animations in my educational talks because I like to break down information. But what I have here on this first slide is a breakdown for how we in cancer genetics define how ovarian cancers develop. So we put them in two categories, either hereditary or sporadic. And hereditary, the hereditary component makes up about 20 to 25% of ovarian cancers. So not all ovarian cancers, but a substantial portion will be caused by being born with a gene mutation or a break in the DNA that significantly increase that person's risk for developing ovarian or other cancers. People who have an inherited mutation that is increasing their risk for cancer could have an ovarian cancer risk from anywhere to 8 to 40%. And that's depending on what gene that mutation was found in. So if you get genetic testing and we know what gene that the mutation is found in, it's not typically that large of a range we're able to quote you, but something much more specific. But the important part of this 8 to 40% number is it does mean that not every person with a gene mutation is going to develop that ovarian cancer. There are still people who have a risk for ovarian cancer that don't develop it. Our other category here is sporadic, and that's how the vast majority of ovarian cancers, and really the vast majority of all cancers, develop. This is where everybody starts off with some risk for developing a cancer. We call that a general population risk. And then those sporadic cancers occur due to a multitude of different risk factors. It's usually not just one thing for any personal tumor diagnosis. So it is maybe a multitude of genetic modifiers playing a role into why that cancer developed, including environmental exposures, lifestyle factors, and many things that we just can't quite explain or pinpoint in a single individual. Every woman starts off with around a 1.3 or 1.2% lifetime risk for developing ovarian cancer. Next slide, please. And we can click on through this slide as well. So I'm often asked, what is a genetic test? Well, genetic testing is looking at the genes that exist in our cells. And so every cell contains this complete set of DNA. And we can think about our DNA like an instruction manual. It's filled with instructions to tell our cells how to function and grow. And then if we think about the DNA as an instruction manual, the genes are the individual instructions that make up that manual. So the DNA is organized into these genes, with every gene having a specific job that it does or instruction that it's giving. So many of the genes that we're testing for when it comes to cancer genetic testing fall under this category of tumor suppressor genes. So these genes that Dr. Secord had already mentioned, the BRCA1 and BRCA2 genes related to Lynch syndrome, these are genes that we're actually all supposed to have. And they should be working, and they should be working to protect us. So go on to the next slide, please. And we can click through this one as well. And so for every gene that we have, oh, I'm sorry, if you go back once. So for every gene that we have, or for most every gene that we have, and certainly all of the tumor suppressor genes, we're going to have two copies. We get one from mom and the other one from dad. And so that's how we're half mom and half dad. And now we can go on to the next slide. We can click through these animations as well. And so here I have a representation of how a sporadic ovarian cancer can develop. So say we start off with a single ovarian cell. Our ovaries are made up of lots and lots of cells, but we're talking about just one cell here. And we start off with two working copies of these protective genes. Well, as we grow in age, damage can be acquired within our cells. So for instance, our cells are making copies of themselves as we grow in age. And every time a cell goes to copy itself, it has to copy all of that DNA, that entire instruction manual that's inside of it. And sometimes mistakes can occur during that process. And if we get to a point where a single ovarian cell loses the function of both copies of a tumor suppressor gene, that's when that cell can no longer function the way that it's supposed to. And it actually starts dividing and replicating itself more quickly than it should. And it continues to become more and more abnormal. And so we can see this progression from a healthy working ovarian cell to an ovarian cancer cell because of acquired damage in our DNA. And if you click, so what this is representing is that those mutations or that damage in the DNA is going to be isolated to the tumor. Our other cells in the body are still going to have working copies of those protective tumor suppressor genes. And importantly, the version of the DNA that we pass on to our children is the version that we are also born with. So we give one of our two copies to our children, but when it's a sporadic cancer, we know that we're starting off with working copies that are passed on. So we're not passing on those mutations that are acquired in the tumor. Next slide, please. And then we can click through these animations. Awesome. And so what we can see here is that somebody who has an inherited risk for cancer or maybe a hereditary cancer syndrome, they start off with one of their protective genes already broken. And it's not a guarantee that that second copy will acquire damage. That's why it's not ever a guarantee that the ovarian cancer will develop, but it does increase the likelihood of the cancer developing when we already start off with some damage in our DNA. That mutated or damaged gene is going to exist in every single cell in our body as well. And according to how important that gene is in preventing cancer and what cell type it's in, in what tissue type it's in or where it is in the body, it depends on if it's associated with other cancer risks. That's why we can see people with a single gene mutation being at risk for more than one type of cancer. And it is in this scenario that the mutation can be passed on to the next generation. Again, we're going to give just one copy to every child that we have. We don't get to choose which copy we pass on, and that's where that 50% chance comes from. Next slide, please. So, and so hereditary cancer occurs when you are born with a mutation that breaks the gene and prevents it from doing its job. And so we can click through, these animations as well. And so a genetic test is looking at the DNA in your cells. It's honing in on these protective tumor suppressor genes. So it's really focusing in on those genes. And it's looking to see, okay, were you born with all of these copies working from the beginning, or were you born with any of them broken? And so sometimes, people who have ovarian cancer might hear from their doctors that they're ordering a genetic test and that's been done on their tumor. And that is different than the type of genetic testing that we offer in the clinical cancer genetics clinic, where we're looking at the other side of the story. What DNA were you actually born with? Next slide. And so we do that by collecting either a blood sample or a saliva sample. Both are typically equally as accurate. So that is what the actual test is, either a blood draw or a saliva sample. You typically only need to do it one time. So, oh goodness, I apologize for how small these words are here, but I will verbalize it. So on this slide, I want to go over why get this testing. So what information are we going to get from the genetic test? And one, it can help guide management for current cancer diagnosis. Dr. Secord had already mentioned this PARP inhibitor therapy that we know is particularly effective for individuals with mutations in their BRCA1 or 2 genes, sometimes called the BRCA genes. So it could let your doctors know which therapies might be next in line for helping address the ovarian cancer. And then certainly we use this information a lot for prevention. So if we can identify a mutation in an individual before they develop cancer, then we try to make moves to either avoid that cancer from occurring or to screen for early detection. Like Dr. Secord had mentioned, unfortunately, right now, ovarian cancer screening is not where we want it to be. Hopefully that changes, likely it will. But right now, the screening is not as effective at detecting it early. And so really the recommendations are typically to surgically remove the ovaries before they can develop cancer, if that is before cancer can ever develop. And because we know that having a single mutation can increase the risk for other types of cancers, it could also let us know if we need to consider risk-reducing surgery in any other area of the body, or more screening. So these syndromes that increase the risk for breast and ovarian cancer, maybe we're talking about removing the ovaries and either removing the breast or screening the breast more frequently, maybe every 6 months versus once a year. Similar for the syndromes that increase the risk for, say, colon and ovarian cancer. If we know that there's a risk for colon cancer, we're not necessarily going to preventatively remove the colon, but we can screen for it with colonoscopies. We might just be doing it more frequently or starting at an earlier age than for somebody who doesn't have the mutation. And then certainly when we identify a mutation, we want to talk about what it means for the rest of the family and get those family members tested so that we can either provide reassurance that they don't have the mutation, or get them or allow them to have these opportunities and get them connected with the right specialist for prevention. Next slide, please. So I just want to mention a few of the syndromes that are associated with ovarian cancer. So certainly hereditary breast and ovarian cancer syndrome are related to the BRCA1 and BRCA2 genes. BRCA1 and BRCA2 are very similar to one another, but they do have little bits of differences between them. If you ever have a mutation in one of these genes, it is important to distinguish between the two. But in general, they're associated with both breast and ovarian cancer. They do have implications for men, being associated with male breast cancer and prostate cancer. We also see some association with pancreatic cancer and melanoma as well. Next slide, please. Lynch syndrome is another syndrome that's associated with ovarian cancer. We see an increased risk largely for colon cancer in the setting of Lynch syndrome, but we can also see risk for uterine cancer along with other cancers of the GI tract in other areas of the body. And there are a handful of different genes that can be associated with Lynch syndrome. And just like Dr. Secord had shown in her slides, each of these genes too have slightly different magnitudes or levels of risk that they're associated with. So if we're able, when we're able to really focus in on what gene we're talking about or what gene the mutation is in, it can really help us give personalized risk management. Next slide, please. And then we also have the genes that at this point or have classically been thought of as really just associated with ovarian cancer. These are RIP1, RAD51C, and RAD51D. These are typically associated with elevated risks for cancers, but not quite as high as what we see with the other syndromes. These would be somebody who has maybe somewhere between a 6 and 12% lifetime risk for ovarian cancer. We can click through the animations on this slide. So what can you do? One is inform your doctors of your family history of cancer. We're learning more and more that our family history gives us information about our own medical history, not just with cancer, but that is certainly the focus of today's conversation. This is something that a few generations back or historically people weren't comfortable talking about. And we're seeing a culture shift where people are becoming more and more comfortable talking about their health history, talking about a cancer diagnosis. We always want to encourage that communication. And if you're ever concerned about your personal or family history of cancer, ask to speak to a genetic counselor, ask for a referral. Genetic counselors were great resources in bridging the gap between genetic testing and what it actually means for the person. Genetic testing, DNA, these are difficult topics. They can be hard to understand sometimes, particularly when you are dealing with the emotional aspects of having a cancer diagnosis or experiencing family members, people that you love, dealing with their cancer diagnosis as well. So genetic counselors, we really try to simplify the information, personalize it, and break it down to say, you know, what is your situation? What is your personal risk profile? And what are your goals from this information? And I think next slide now. And that's all I have for you all today. Thank you again for this opportunity.
Thank you very much, Maggie, for that wonderful, one of the most simplistic ways of looking at DNA and how it functions. So we really appreciate that. Our next speaker is Dr. Denise Bell. Dr. Bell earned her Bachelor of Science degree in Public Health Education from North Carolina Central University. With a concentration, and she received her master's in public health with a concentration in community health from the University of Greensboro. So her and Maggie went to the same school. And Dr. Bell also received a PhD in public health from Walden University. She currently serves as a grant writer, manager, and director of community outreach programs for a federally qualified community health center. Dr. Bell is an enthusiastic, lifelong learner, health equity advocate who is interested in social science behavior tools, health services research aimed at eradicating health disparities. She's a 2-year stage 3 ovarian cancer survivor and multiple sclerosis thriver for over 24 years. We truly thank Dr. Bell for sharing her story with us today.
Thank you so much. Can everyone hear me okay?
Yes, we can hear you.
Wonderful. And I apologize that my video option is not working on my laptop. And so I'm very disappointed that you all can't see my smiling face. And so again, thank you so much for allowing me this opportunity to briefly share my story about my cancer journey. Next slide, please. So my story started when I was 43 years old, and over a period of a week, I noticed my abdomen was swelling, similar to what Dr. Secord was mentioning earlier. The more it swelled, the more I looked pregnant. Now, one might celebrate this possibility. However, due to prior surgeries, I knew this was not a possibility. Another symptom that I was experiencing was shortness of breath when walking for long periods and difficulty sleeping due to my inability to lay fat. And as you see there in the picture, I do appear to be at least 3 months pregnant, but unfortunately, that was not the case. And since I have lived with multiple sclerosis for over 24 years now, I immediately thought these symptoms were related to MS, right? Why not? Oh, how I was wrong. And it just so happened the time that I was diagnosed, I had an annual MS checkup with my Duke neurologist. And thankfully, because my MS was considered stable and the symptoms were obviously not tied to MS, my neurologist immediately sent me to the ER for additional tests. A CAT scan was performed and my cancer journey begins with stage 3 ovarian cancer. Next slide, please. As you can imagine, I was anxious due to enormous uncertainty. Many questions about treatment options. Will I be able to survive this diagnosis? And the list goes on. I may not have known the outcome at the time, but one thing is certain. I had passion to live. And as we all know, living in uncertainty, a quote that I was able to locate that really resonated with me was, it is an act of courage to acknowledge our own uncertainty and sit with it for a while. And that author is listed here on the slide. Next slide, please. So my treatment begins. My treatment consisted of several abdomen drains for ascites, or ascites, I probably mispronounced that, so please forgive me, Dr. Zacord, 6 rounds of chemo, a full hysterectomy, and almost 2 years on oral maintenance medicines. Now, I must admit that I remind others when they recognize my personality shifts a bit that I woke up like this, especially if there seems to be signs of menopause. The pictures that you see here on the far left is the fluid that was initially drained from my abdomen. The first picture next to that is my second treatment for chemo. The middle picture was my 3rd or 4th treatment for chemo. And the picture next to that, the last picture is actually a picture of my first treatment with chemo. Next slide, please. Now, as mentioned earlier in the presentation regarding genetic testing, I would highly encourage everyone to receive genetic testing. The information is enormous and is so impactful, especially if you share this information with your family. And so I was tested and I learned that I have the BRCA1 cancer mutation gene. And my mother was also tested and learned that she's the carrier. And this is a picture of my mother and I. She's one of my sheroes. My mother is an 11-year breast cancer survivor. And because of this news regarding the BRCA1 gene, I decided 2 years ago to have a double mastectomy since I was at risk of over 85% of developing advanced cancer. Now, as we all know, we may not have control over every aspect of our lives. And I recognize this, right? But I may not be able to control another cancer diagnosis. I'm okay with that. However, my way of taking some control to reduce my chances of breast cancer was electing to have a double mastectomy. I had the surgery on September the 14th. Yes, I said September the 14th, and that was 10 days ago, which is why I'm in the car, because I recently had a post-op appointment today. Everything is going well. Now, my risk has dropped drastically to less than 2%. So the genetic testing helped me to make a very important decision that will hopefully extend my life expectancy. Next slide, please. I would be remiss if I did not acknowledge the individuals in these pictures. Please don't ask me to remember all of their names, but I hope that they know that I truly, truly appreciate all of their support and all of their encouragement and for helping to save my life. If it was not for Duke Oncology team, I don't really think I would be here today based on my diagnoses. On the left side, the picture to the left is my last chemo when I was able to ring that bell. And as every cancer survivor remembers, that opportunity to ring that bell is so paramount. You know, you get emotional thinking about it because you feel like you can now take a sigh of breath, a deep breath and say, or a sigh of relief, I should say, and say, I actually made it. On the right is my phenomenal oncology medical team. And I know there are some familiar faces because you see Dr. Secord there. These ladies are the reason why I'm so passionate about sharing my story with others, particularly African-American women, to encourage them to not delay screenings, to not delay medical treatment, because as we know, early detection is key. And if we are diagnosed earlier, our options for treatment is a lot greater. And I'd like to thank all of them and all of you for giving me this opportunity to briefly share my story.
Wow, that's all I can say. All three presenters, excellent information. I know I certainly learned a lot. And you know, and for me personally, I've lost an aunt to ovarian cancer. I lost a very close friend last year to ovarian cancer. She was diagnosed in her 40s. I do have another friend that's a survivor. But this is, you know, a topic that I wanted to address because not a lot of information is being placed on ovarian cancer since it cannot really be screened for. But I do have a question for you, Dr. Secord. A question that we had sent to us was, if you had a partial hysterectomy and the blood flow to the ovaries have been ceased, should you continue having yearly vaginal examinations to check for irregular growth?
Oh my goodness, that's such a great question. Can I just pause for a moment?
Yes.
I just want to say to Maggie Powell, fabulous way to break down and have that conversation about genetic testing and simplify it. That was fantastic. And then for Dr. Bell, I'm just wowed. Like, wow, wow, wow. That was an amazing, amazing story. And I love seeing her and her mom in clinic. It's just great. It brings a smile to my face. Right now, I have to fight back tears because that just story was so profoundly amazing. But thank you for sharing, because I think it takes a lot of courage to share. And I hope that you can talk again, because I'm just inspired and blown away. And I think others will be too. Now to your question. So as a gynecologist, the pelvic exam is what I do. I think it's an art form. That's like going to a cardiologist and not having your heart listened to, you know, but there is a lot of information now saying that women don't necessarily need to have a pelvic exam. And that could be the case when you're seeing your doctor, you know, once a year for your well woman visit or your physical examination. But I'm a firm believer in doing a full pelvic exam still. And your ovaries may be out, or your ovaries are probably still in, your uterus may be out. That does reduce your risk, obviously, of cervical cancer and uterine cancers. It will also reduce your risk of ovarian cancer, but it doesn't make it zero. There are some patients, and it may be a small number, but there are some patients that they are diagnosed with their ovarian cancer at the time of a physical exam. A doctor just picks up a mass. Now that can happen and it'll be benign, but I guess I'm still, you know, this is my training. This is what I do. So I still feel like it's worthwhile to have an annual exam, and including a pelvic exam.
Excellent.
It might be worthwhile to, can I just, one more thing? If you've had
go right ahead.
Go and check your op report and see if they remove the tubes. If they remove the tubes, that will greatly reduce your risk of these types of cancers.
Excellent. Thank you for that thorough explanation. I do have a question for Maggie. It was great to learn about DNA testing. And like you indicated before, a lot of people have been afraid to do DNA testing. You know, people question and have fear of what's going to happen to the results. But from what you know, is DNA testing covered by health insurance? I know this is a question that I normally get in the community.
Yes, and that is a great question because the finance aspect of our healthcare is it's an unfortunate reality, and the short answer is yes. Yes, when medically indicated. So if you have a family history of ovarian cancer, there's a really good chance that you would have insurance coverage for the test. Genetic counselors are also really well connected with the different genetic testing laboratories. So we know when somebody, we know which labs will run testing if there is a clinical or if there's a medical reason to do so, but maybe that patient is uninsured, or maybe they're underinsured. So you can say, well, my insurance might cover a part of it, but what about the other part that isn't covered? So we do work with labs that do transparent billing, that will, again, in some cases can waive the cost of the test if you're uninsured. And then a phenomenal fact that I like to say, because it's a surprise to a lot of people, is that the out-of-pocket cost, so somebody who is insured maybe doesn't have all of the medical indications that insurance says that you need the testing, the out-of-pocket cost is $250 for a lot of this testing right now. And that's not a negligible amount of money, but not too long ago, it was a multi-$1,000 test. So it is becoming more and more accessible.
Thank you very much, Maggie. I have a question for Dr. Bell. Listening at Dr. Sequoia's presentation and hearing your journey, I know a lot of the signs and symptoms seem like normal signs and symptoms that women deal with. What advice would you give a woman that are having some of these signs and symptoms and they go to their provider and they kind of discount it? What advice would you give them as a way to advocate for themselves?
Oh, great question. In my current profession, I do this a lot with women of all races. And the one thing, as we know in society, is that, we each have our roles, men and women, right? And so a lot of times women are really sometimes the foundation of their family. We're the ones to keep everyone organized, to keep everyone's schedule together, to keep everyone on track of when they're due for a physical, a dental appointment, an eye appointment, and the list goes on. However, in doing that, we often find ourselves putting ourselves at the bottom of that list of priorities. And so one thing that I've learned through my, understanding ovarian cancer and my conversations with Dr. Secord and my other oncology team is that, my symptoms, or my cancer, I should say, could have been growing over the past 3 to 6 months before I was actually diagnosed, and would have not have known that. The only reason why I knew something was wrong was because of my swollen abdomen. And it was something that I couldn't just overlook, right? I couldn't put it, I could have, but I chose not to. And so I encourage individuals to make sure that, you take time for yourself and you make yourself a priority, because if you are not at 100% level, or I should say, you're not healthy and you're not taking care of your needs, and how can you possibly take care of someone else's needs? And so too often what I'm seeing is that women in particular are receiving late stage diagnoses because they saw something, they felt something, but chose not to do something. And so I'm encouraging them, and a huge advocate for this is to really make sure that if you feel something, you see something in your gut, something is wrong, because we all should be in tune with our bodies, and we know when something's not quite right. Even if a doctor says they can't find anything, but we still know something's not right, act upon it. Please seek medical advice. I also deal with home remedies, and some home remedies are great, right? However, home remedies won't cure sometimes, or, home remedies I know would not have cured me from ovarian cancer. And so to answer your question, is really advocating for people to be proactive about their health and their health care, and to make sure that they do something when they feel something or see something, and to make sure they act upon it.
Thank you very much for that response. I have one more question, and all three of you all can chime in. I'm a male, and so I don't know what it's like to be a female and have these signs and symptoms. So what advice, there may be some males on the call here, or some may be listening to the recording after this is over. What advice would you give males on how can they support their partner that's going through some of these symptoms?
Well, I think the thing there, Dr. Moore, and I haven't thought about it from this perspective, but I think it's really important and kind of ties in with what Dr. Bell was saying, is that they say, hey, I think something's wrong and you should go see your healthcare provider. And, you also alluded to this in your other question. If you go to a healthcare provider and you feel like they're not responding to your concerns, and I mentioned this in my talk, sometimes you may have to say, I'm worried that some of my symptoms may be ovarian cancer symptoms, and what would you recommend? And can I have an ultrasound, or can I have a CT scan? I mean, and the key here is that these symptoms are very nonspecific, but if you have them every day for 2 to 3 weeks and they're not getting better, that's a sign to get medical care. And what Dr. Bell was describing with her symptoms is a definite sign that something's not quite right. And she was very fortunate that her physician sent her to the ER right away. So to answer your question again, so sorry to go on too long, but I think that the partner can just be really supportive and recommend that they go see somebody. And then during the treatment, just, a lot of tender love and care.
Thank you. Anyone else?
Yes, Dr. Moore, I'd like to also add, I totally agree with, of course, what Dr. Secord mentioned, but I would just add that keeping a non-judgmental mindset or attitude is always helpful, and to meet the person where they are. And so you just really want to be respectful of an individual's decision as it relates to their health, as we know, and just provide encouragement. I think that is also very helpful during those times.
Great, thank you. Maggie, anything for you?
That I agree with what has just been said, and that the default reaction should be belief, that you are believing your partner, your sister, your mother in what they are describing. They know their bodies, they know what is their normal and what is different, and in belief.
Yes, thank you. And I would add one last thing. I like to teach patients that they need to be their own advocate. And, when you have a provider that you feel is not listening to you, some patients just do not know that you have a choice. You can find another provider that will listen to you. So for those who are listening, I want to make sure that you are aware of that. You have the power, it's your body. So thank you very much for this great presentation. My contact information is here, so you can send me any questions, anything that we have not been able to discuss or answer. I just want to tell you, we do have some upcoming events. The month of October is Breast Cancer Awareness Month. And so on October the 2nd, we have a program called What's Best for Breasts. And we have a lot of breast and health specialists that will provide short presentations, as well as we'll have some of my staff, community-facing navigators, that will help you get mammograms that you would need, or if you need to be connected to a primary care provider. Also, October the 22nd and October the 23rd, the Office of Health Equity, we have a training program called Health Ambassador Training Program. And what we do is we teach individuals that belong to a faith-based organization or any community-based organization that have a desire to help people. We teach them some of the common cancers that they should be screening for. We teach them what are some risk factors. We also teach them about cardiovascular disease like hypertension, as well as diabetes. Those are some chronic conditions that really put you at risk for cancer. So this is a training, it's a 4-hour virtual training. We offer it for free. If you have a health ministry in your church, and you would like to have additional information to add that cancer to your program, I encourage you to attend this training. Or if you belong to an organization, you don't have a healthcare team, we also encourage you to take this training so you can teach people this information so they can advocate for themselves. Because this is one way that we can help reduce health disparities by giving this education to people. You have to have education to know when you need to screen for cancer, what some of those things look like, what are the tests, the screening tests, how often you should do it. So we equip you with a lot of information. So our information is right here below. And hopefully you can join us for that training. And at the end, thank you to all the presenters that presented their information, that increased our knowledge tonight, as well as the individuals that participated in the program. We just want to thank you and wish you have a great weekend. Goodbye, everyone.
Thank you. Good night. Bye-bye.